Hi, this is Brian Kim. I'm going to share with you case number 198 in the Best Way to Do Cataract Surgery series. This is a patient with a cataract as well as posterior synechia, and you're going to see a posterior synechiolysis technique as well as a toric IOL. This patient has astigmatism. And then you're going to see systematic mechanical fracturing performing with double chop, cross chop, mechanical forces to crush the lens into smaller pieces. Again, this is a very careful and systematic way to disassemble the lens with sparing amounts of ultrasonic energy and vacuum. So you can see the marks that I made while the patient was sitting up in the pre-op area. And then I'm using the corneal mark, which will help me to center and size the rexus. You can see this eccentric pupil is not going to be helpful as a cue to mark the central cornea. And so using the corneal marker is rather helpful in this situation because you can't use the pupil as a cue because of the eccentric pupil. So go ahead and make my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. I'm using the cannula to visco-dissect the posterior synechia off the anterior capsule, and then using some blunt forces with the cannula. This is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. These are the sharp tip Haldane-Perkar forceps. I'm using it to actually grasp the edge of the synechia, and then I'm pulling the synechia off the iris. So again, the problem with the synechia is it's causing relative contracture of the iris tissue and exacerbating that asymmetry. And so by peeling off that fibrotic tissue from the pupil and the pupillary membrane, I'm able to get a better centered pupil. I remove that tissue off and then go ahead and start the rexus with the forceps. I puncture the center, pull down towards me, grabbing the right side of the tear, and then I'm going around circumferentially, trying to use the corneal mark that I made for my Capsulorhexis so that I can achieve a well-centered and sized rexus and lens position. So again, I can't use the pupil, so I have to use that corneal mark, again, because the pupil is eccentric. This is the Capsulorhexis hydrodissection technique. I place a cannula under the rexus edge contra-incisionally, get a nice wave. I'm lifting the lens up, decompressing the bag. By doing it this way, you can make sure that there's absolutely no capsule block situation. And then I'm able to rotate the lens quite nicely here without any difficulty. I had a visiting surgeon with me that day, and he wanted me to actually try some hydrodelineation as well. So I went ahead and tried to hydrodelineate. Not sure how good of a job I did there. So I go ahead and lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Placing the chopper under the rexus edge contra-incisionally, point the tip down, rotating the phaco tip vertically sub-incisionally, fracturing the lens completely in half. That's double chop, placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally, crushing the lens against the phaco tip, and that is cross chop. Getting around that first quadrant and crushing the lens into smaller pieces and then emulsifying the lens piece. Getting around that second quadrant and performing another cross chop maneuver, crushing the lens into smaller pieces and then emulsifying the lens piece. Turning the second heminucleus in front of me, placing the chopper again under the rexus edge, hooking the peripheral lens, pulling it centrally toward the phaco tip, crushing the lens against the phaco tip. Again, that is another cross chop maneuver. Grabbing that third quadrant, crushing the lens into smaller and smaller pieces, and then emulsifying the lens piece. Placing the chopper around that fourth quadrant, hooking the peripheral lens. It kind of turned in a funny way, so I just used some vacuum to grab the lens, and then I was able to place a chopper around it, crush it into smaller and smaller pieces, and then emulsify the lens piece. This is really not a dense lens, maybe a 1 to 2 plus dense lens. Rather thick epinuclear material, grabbing the edges of the epinucleus. Again, it's rather tough. Thick and sticky, that's what I would call it. Going around, again, using the chopper to loosen up the lens and then crushing it into smaller pieces, using the chopper and phaco tip to crush it. And then using high vacuum to basically carefully remove the lens pieces. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the eye in a handpiece. I always start sub-incisionally, peeling from anterior to posterior. This is the cleanest way to remove the cortex, the most efficient way, because it doesn't tend to leave those fine wispy lens material. Switch to polish mode, polishing under the rhexis edge. Polishing the posterior capsule as well. This patient obviously had a bout of iritis. That's why there was posterior synechia. I really don't want to leave any lens material in this case. So again, meticulous cleanup is very important because this patient had a history for iritis. Pulsing some BSS into the subincisional capsule fornix. It was clean. Pushing some cohesive viscoelastic into the capsular bag. Turn irrigation off first. Filling up the bag. And then polishing under the rhexis edge with the sweep. First on the left side and then the right side. You saw I kept that cannula there because this patient's belling up. This is the right eye. This patient was belling up. So I kept the cannula, viscoelastic cannula there, which kept the eye more centered as I was doing the sweep. So another little trick. You can always take advantage of your incisions and your instruments to control the eye whenever you can with a second instrument. Placing the single piece acrylic lens into the capsular bag. Going in with irrigation off, activate irrigation. Tilting the lens, getting under it. Again, this is going to be a toric lens, so I want to make sure both haptics are in the bag. Removing all the viscoelastic from within the bag. Repositing the optic back down. And then here, I just thought to myself, I need to get that little tag off. And so I stop, come out, push some viscoelastic through that incision, and it caused that little tag to come away. And then I use the scissors to just amputate it. So again, using the viscoelastic to control that little tag. And then I go back, removing the viscoelastic from within the bag again. Removing the viscoelastic from the anterior chamber. Polishing underneath the rhexis edge one more time. Switching to visco mode, removing all the viscoelastic from the anterior chamber. I will have to align this toric lens. You can see how the rhexis is actually rather well centered on the optic because I marked it before. So I'm going ahead and with irrigation on, I'm turning the lens counterclockwise, which is safe, and I'm using the INA tip in order to turn it. There was some fine material there, so I'm going underneath the lens and polishing that off. Pushing the optic back down. Again, I'm turning the lens counterclockwise a little bit, And then I'm placing the ring again just to see where I need it to be. And when you have just a little subtle movements, again, with the infusion on, when the bag is completely inflated, it's not really holding on to the lens. And so it's safe to go ahead and turn the lens one way or the other, and it should effectively turn the lens because it's not catching on the capsular bag. Never try to rotate the lens when you're not actively putting infusion in. That is, it makes no sense to do that. Turn on infusion, fill the bag up, and then reposition the lens. If you're not doing that, you're just pulling on the bag and the zonules. So you can see excellent position of the lens now at the end of the case. Again, this patient had posterior synechia, and I did a visco removal of the synechia. It maintained this asymmetric and eccentric pupil, and so that was because of a pupillary membrane. I went ahead and grabbed it with my Rexis forceps and peeled the membrane off. It left a little bit of a tag, so I used micro scissors to cut that tag, and I performed double chop, cross chop, mechanical fracturing techniques as I normally do. I made a Rexis that was centered over the center, not over the pupil. And so as a result, I was able to get a well-centered and sized Rexis with 360 degrees overlap of the optic. Again, you have to do that when the pupil is eccentric. And I was able to perform, again, mechanical fracturing, double chop, cross chop. This patient has a nice clear cornea at the end of the surgery. And we were able to neutralize all of that astigmatism. And at the end of the case, because this patient had a history for uveitis, go ahead and inject a little bit of Kenalog in the subconjunctival space. And this was the end of the case. And the patient did well. So I hope this was helpful to you. And I thank you for your attention.